Welcome back to part 2 of our healthcare provider webinar series on the cardiovascular and metabolic impact of insomnia, how sleep can be contributing to the problem. Today, we're going to talk about non-pharmacological approaches folks can take to support people living with diabetes and insomnia. So I'm excited to introduce Dr. James Kim as the speaker once again. Dr. Kim is a clinical assistant professor in the Department of Family Medicine at the University of Calgary. Dr. Kim has a special interest in diabetes, metabolic dysfunction associated steatotic liver disease, or MASLD, and chronic migraine. Since completing his master's program in the healthcare professional education, Dr. Kim's interest lies in effective healthcare professional education education delivery methods, and has been invited as a guest lecturer at a number of universities and conferences on this topic. He's also the lead editor for the primary care section of the Canadian Journal of Diabetes and co-editor for the Canadian Primary Care Today Journal. And at Diabetes Canada, his role includes the steering committee member for the clinical practice guidelines, current co-chair of the Primary Care Special Interest Group, a dissemination and implementation committee member, and then the author of the guidelines, including being the lead author of the MASLD guidelines. So without further ado, I'll pass it over to you, Dr. Kim.
Thank you so much, Grace, and thank you for having me once again. So for this part 2, I hope that you have listened to the part 1 and hope that was an interest to you. And hopefully I have convinced you that insomnia should probably be considered as an independent risk factor for cardiovascular and metabolic issues. So today we're going to talk about the non-pharmacological interventions for our patients living with insomnia. So when you look at the goal of insomnia management, it is really to increase the sleep quality, followed by sleep quantity, and also reduce the daytime symptoms. So as I've mentioned in part 1, American Diabetes Association actually stated that they would give a very strong recommendations and based on the evidence, very strong evidence that if the person has a really good sleep quality, then it will really reduce their A1C, their blood glucose, cholesterol, blood pressure, and so on. And then if they do have a better sleep quantity of sleep, then there is still a good benefit for all those metabolic profile as well. And one question that I would ask our patients, whether their insomnia is improved or not, is actually asking the next day function. So when you wake up in the morning, do you feel refreshed? Do you feel fatigued? And or do you feel cognitively perfectly fine? Or do you feel like there's a cognitive dysfunction? So those are the questions that will determine whether I'm actually doing my job in managing insomnia. Because they could tell me that, they could be sleeping 7, 8, 9 hours a day. And yet if they wake up early in the morning and feeling not refreshed, maybe I haven't really improved their sleep issues. So then the whole insomnia needs to be looked at again. So the first line of the managing insomnia is actually cognitive behavioral therapy for insomnia. We call it CBTI. If it works well, then the duration of the efficacy of the CBTI lasts for a very long time, and it is a preferred choice of management for insomnia. It depends on whatever guideline you look at. The problem is adherence, because as you may know, the lifestyle management is probably the most difficult prescription for the patients to really adhere. And a number of the meta-analyses actually have shown that CBTI alone may not be very effective, so may require some pharmacological interventions as well. However, it is the preferred treatment of choice in many guidelines, and it is something that I have personally found to be very effective in my clinic as well. So I want to share with you some of the CBTIs that you can do in your clinic. The number one, the most important thing, I believe, is a stimulus control. So the person needs to associate, or the person's brain needs to associate the bed with sleep. So actually the purpose of bed is 2 S's, right? So that's sleep and sex. So that is what the purpose of the bed is. So therefore, the person should not be reading books, watching TV, eat on bed, or even study on bed, because that is not recommended. Because then now the purpose of the bed becomes not for sleep and sex, it actually becomes something else as well. Therefore, the brain doesn't associate bed with sleep. So that is really important. So some people say that no, you should not look at your cell phone about 3 hours before you go to bed. Well, if that happens in bed, I think it should never happen, period. If they were to use a cell phone, yes, I agree that 3 hours before going to bed is important, or not looking at your phone for 3 hours before you go to bed is important, but that should never happen in bed. So bed needs to be associated with sleep for people with insomnia. Sleep restriction is a very interesting technique. So when I first heard about the sleep restriction technique, I thought that that was like really dumb. Why would you want to restrict a person from sleep when they already have a sleep problem? So the way it works with a sleep restriction is like this. Johnny wants to go to bed. Well, he goes to bed at 10 p.m. and he falls asleep at 12 a.m. Now, there is no point of Johnny going to bed before 12 a.m. because he's not going to fall asleep. So what you do is that you get Johnny to sleep at about 12:30, and then make sure that he actually sleeps. And as he sleeps well, you take 15 minutes away. So this could take literally a couple of weeks or a couple of months. I remember very first time that I was explaining about the sleep restriction to my patient. And as I was telling him about how to do a sleep restriction in my head, I was like thinking, this is not going to work. This is so dumb. This doesn't make sense. But you know what? A couple of months later, the person actually came back and said, you know what, Dr. Kim, I am actually sleeping at 10 p.m. now. So it actually works really well. Sleep hygiene is very important. See, avoiding napping and limiting caffeine and alcohol intake is very, very important. The best time to nap is actually 12 hours before you actually go to bed. That's what I've been told by the sleep specialist. For example, if you were to go to bed at 10 p.m., then the best time to nap is 12 hours earlier than that. So that's at 10 a.m. And the best duration of napping is 20 minutes. So in most patients, that's not feasible. So we just say that don't nap. Now, caffeine intake is an interesting one. So I've been told by some specialists that caffeine can actually last in your body for more than 24 hours. Therefore, if you are concerned about someone with insomnia and they tell you that, no, I only drink coffee or tea, because tea also has a lot of caffeine in it before 12 p.m., so I should be fine. The answer is probably not fine. Trying to get them off as much caffeine in a gradual fashion is very, very important as well. A number of other cognitive therapies or relaxation therapy may be important. I cannot remember if it's a BC Anxiety or Anxiety BC website has a really good tools for our patients in relaxation therapy. This is the a list of resources available for our patients. So I give this to our patients if needed. Some of them are free, some of them they have to pay for, and it has been serving me really well. Just to briefly introduce you some of the actual medications indicated for insomnia in Canada. So the first two medications are dual orexin receptor antagonist. It is amazing. So I love these two drugs. For me, this is like semaglutide or like GLP-1 receptor agonist. You know how when the sugar goes up and then the GLP-1 receptor agonist medication really works, and when your sugar is normal or low, it actually doesn't do anything to lower your sugar further. So it's a nice safety switch in terms of lowering the sugar from GLP-1 receptor agonist, and it doesn't actually cause hypoglycemia. So it's kind of the same thing. In people with insomnia, we feel that it's because the orexin level is too high. Orexin is a neuropeptide that keeps you awake. And in many patients with insomnia, orexin level is too high, so then your brain goes like nuts, basically. And all these medications do is basically reduce that orexin level to the normal level so that the person can actually sleep. Therefore, there is actually a lot less side effect the next day, such as the Z drugs, Lunesta, but the zopiclones and zolpidem can actually cause the sedations the next day as well, and benzodiazepines as well. And by the way, the Z drugs and benzodiazepines, their efficacy actually wanes with time. People develop tachyphylaxis, so you need more and more medications to actually achieve the same efficacy as well. Doxepin is probably the least used medications, and we use it for very specific patients. Now, what about the off-label medications? So there are some benzo medications that I tend to avoid. Mirtazapine I avoid because it causes quite a bit of a weight gain, and appetite goes up as well. One of the sleep doctors says that mirtazapine is very, very likely to cause weight gain, so much that if your patient is on quetiapine, then you're likely to gain weight. If your patient is on mirtazapine, the patient will gain weight. So when we're dealing with people with already compromised metabolic or cardiovascular conditions, maybe we should avoid medications like mirtazapine or quetiapine. Trazodone is an antidepressant. It works really well in some patients. However, it does cause sedations, orthostatic hypotensions, dryness of the mouth and dizziness, and so on. So may have to be careful, especially in elderly patients. Amitriptyline and nortriptyline are very interesting medications because it does work in some people. However, some sleep doctors actually said that although it can increase the sleep durations, it may actually destroy the sleep quality as well. So please do ask your patients about all the potential side effects that you can get from amitriptyline and nortriptyline, which also includes the weight gain as well. And just ask them if they actually have slept well. So those are very important questions to ask. In terms of so-called the natural medications, the one that we tend to use mostly is melatonin. I have been told by some sleep doctors that if a patient uses melatonin for more than 2 weeks in a row, then that person probably needs to be investigated further and preferably also be seen by the sleep doctors as well, because the purpose of melatonin is not to be used for more than 2 weeks. And please have a look at the dosage recommendations. It's from 0.3 milligrams to 6 milligrams. So in the pharmacy, you will see the melatonin going up to 10 milligrams as well. And there's no need for patients to use up to 10 milligrams. So please watch out for that. So the key learning point is that it is critical that the healthcare providers like ourselves need to screen all people living with diabetes for insomnia to reduce their cardiovascular risk. There are a number of CBTI techniques that we can apply in our clinic to aid with insomnia, and healthcare providers should ask questions regarding the next day function to really determine if the person is sleeping well or not. So I hope that has been useful, and I hope we can all screen our patients living with type 2 diabetes for insomnia, and hopefully we can reduce their further cardiovascular risk reductions. Thank you so much.